We are live. We are live, sir.
Good afternoon to everyone, and sincerely hope that you and your family members are safe and healthy. And welcome back to the second session and of this virtual event, which is organized as part of the 75th year of Indian independence, Azadi Ka Amrit Mahotsav. And this session is interesting in terms of its topic, where we would be discussing about some of the unmet challenges and engineering opportunities that lie in the area of transplantation. So when we talk about organ transplantation, even for a layman, he immediately comes up with four quick things about the organ shortage. The second one on the logistics of transportation, since they cannot be stored for a long time. Sometimes the immunological rejections, and finally, of course, the cost of these transplantation surgeries. So in this session, we have three eminent and successful transplant surgeons in the areas of heart and lung, kidney, and liver, who will articulate the unmet engineering challenges in these domains. So it is my pleasure to introduce and welcome all the panelists. And first, I would introduce Dr. K.R. Balakrishnan, who is currently the director of the Institute of Heart and Lung Transplant, which is India's largest heart transplant center at the MGM Healthcare, Chennai. He is also an adjunct professor of engineering design at the Indian Institute of Technology, Madras. With over 40 years of experience in cardiac thoracic surgery, he has done over 20,000 heart operations with more than 350 heart transplants, 35 heart and lung transplants, and about 70 lung transplants. He is also an innovator in the field, where he was successful in India's first HVAD, which is the smallest heart pump in the world, in 2013. And he also developed India's first successful LVAD implant surgery, the HeartMate 2, as a destination therapy in 2012. He's performed India's youngest pediatric heart transplant on an 11-month-old baby, and India's youngest bilateral lung transplant in a 4-year-old child. So in his free time, Dr. Balakrishnan is also a musician who plays the saxophone and the harmonica and the clarinet. He has his own YouTube channel, and he also plays in a band. So we are proud to have you as part of this panel, and we welcome you to this panel, sir. The second panelist is Dr. Rajan Ravichandran, who graduated from Bombay University in Medicine and Surgery with several awards and gold medals, and started his practice at Chennai in 1985. With over 35 years of practice, he has treated more than 20,000 national and international patients with renal disorders. He has performed more than 1,000 renal transplants and about 1,000 to 1,500 hemodialysis every month, out of which about 20% of patients are given free consultation and the medical device. In July 2008, he started the Mayotte Institute of Nephrology and has set up a 100-bedded unit to treat patients with kidney diseases. He is also an innovator and has developed the acute dialysis machine that is used in critical patients to remove fluid to treat pulmonary edema. He is also credited for the development of polyallyl amine phosphate binder, which is also used orally to remove phosphorus in patients with chronic kidney diseases. It's a pleasure to have you, sir. Our third panelist is Dr. Mettu Srinivas Reddy, who is the director of the liver transplantation and HVP surgery at Gleneagles Global Hospital and Health City, Chennai. Dr. Srinivas Reddy underwent medical training at JIPMER and general surgery residency at PGI Chandigarh. He underwent training in liver transplantation in UK, completing all the fellowship in Newcastle upon Tyne and Leeds, and was awarded the FRCS in general surgery and transplant. His PhD doctoral research was into novel organ preservation techniques. Dr. Reddy returned to India in 2012 to join the Global Hospitals Chennai as a senior consultant surgeon. He also served as the director of the liver transplantation in Dr. Raila Institute and Medical Center, Chennai until October 2020, before taking up his current position. His clinical expertise include pediatric liver transplantation, ABO incompatible liver transplantation, surgery for liver and pancreatic cancer. And his research areas of expertise are organ preservation and ischemia reperfusion injury and mechanics of liver regeneration. So with these brief introductory remarks about the three panelists, we welcome you, all the three of you, to the panel. And now I hand over the floor to Dr. K.R. Balakrishnan to moderate the session and also invite him to speak on the challenges in the area of heart and lung transplant. Thank you so much.
Thank you very much. I think Dr. Murthy was unavailable, so he's asked me to take over. And I think I'll speak first and then the others two can speak. And after that, we'll have some kind of a discussion. So if I can share my screen. Are you able to see my screen?
Yeah. Yes, sir.
Okay. Thank you very much for this opportunity. I understand this meeting is about medical devices in general, and the faculty involves engineers, students, and perhaps people from the industry. While the theme might be on transplantation, at least I didn't think it would be of any interest if we spoke only about the clinical aspects of transplantation, which might be of very little interest to this audience. I thought I'll share some of my perspectives on medical device development in India, especially from the perspective of a heart transplant program or a cardiac surgeon. And I've titled The Good, Bad, and the Ugly. Unfortunately, the reality of Indian medical device sector is pretty gloomy. The industry is small with a disproportionate reliance on imports, and every year and every few months, the cost of the exchange of dollar or euro goes up. And then there is a commotion and cry that costs are going up and hospitals are overcharging. To a large extent, this is an impossible situation unless we start doing some things of our own. I got some more interesting statistics. The per capita spending on medical devices in India is amongst the lowest amongst the BRIC countries at $3 as compared to 42 in Russia and 21 in Brazil and 340 in the United States. We have an industry which is largely dependent on imports, with most of the local manufacturing is low-end products like Ryle's tubes and catheters and perhaps some cannulae. Anything more sophisticated. And of course, we make surgical instruments are reasonable, but more technically advanced projects, perhaps ophthalmology is an exception, but most of the stuff that we use in our specialty are imported. Funding and technology access is poor. And most importantly, there's a very ambiguous, complex, and lack of transparency in the regulatory environment. And all these are holding things back. We had several policy initiative announcements, Make in India. All of them are attractive in principle and tend to cheer you up, but policy announcements alone achieve very little. We need to ask why this has not happened in 70 years of independence, that suddenly we have to wake up and start making in India over the last few years. I'm sure Ravi and Dr. Reddy will speak from the perspective of their own specialities. But if you look at the high-tech Indian devices in the cardiovascular market, they're pretty scanty. The valve that you see is a Sri Chitra valve. It was developed by Professor Veliathan almost 30 years ago by actually copying the Bjork-Shiley, which was a popular valve at that time. This was done with the funding from the Department of Science and Technology, and they established a pretty good center for research in Trivandrum, funded by the government. In those days, I don't think they thought about CE mark or FDA, or their main aim was to enter the market within this country. And as things stand, it's been a pretty successful pump. It's used in large numbers. We use it with good results. But unfortunately, its penetration to markets other than India and some African countries is very poor. Everyone wants a CE mark. Even in this country, All India Institute, South Asian Hospital, all the central government institutes insist on FDA approval for some reason. So I wouldn't call it a spectacular success, though it has, I think it remains to date the most successful implant that we have made locally. We have several stents are now being manufactured. They're not high tech now. They become more of a commodity. And this valve, percutaneously implantable valve, was developed by a company out of Gujarat, and that's been a pretty successful. I think they got a CE mark now, so they are allowed to sell in Europe. I'm not very sure as to where the development work was done because I visited the factory. It's very good, but their design engineering team, I'm not sure whether it was outsourced to some other country or whether this model was based upon development somewhere else. I think they do the animal work in Washington. But these are the only three examples I could find of important implantable devices in the cardiovascular market in this country. So what are the good things that we have? There are several good things. India has great design capabilities on computer simulations, computational fluid dynamics, finite elements, are all excellent, world class. I do a lot of work with IIT Madras and as does Dr. Ravichandran. So we have some idea about the strengths, and the strengths are very good. So we have done a lot of fundamental work with IIT Madras, and these papers have been published in leading. In fact, this article of us in the aortic valve was rated as amongst the 200 most influential papers ever to be published in the history of the aortic valve. And as we speak, it's got over 500 citations. So as far as academics go, it's pretty impressive. It has received, and is the most commonly quoted article. We have several of these in very prestigious journals, including Journal of Biomechanics. We also looked at modeling why heart attacks happen by modeling plaque rupture by looking at the stresses in plaques. And this is published in the British Heart Journal, including the effect of calcification and plaque stresses. So these are great strengths. Now, more recently, we looked at why strokes happen in artificial heart pumps and published this in the, this is actually a keynote presentation in the American Society of Artificial Internal Organs. And for those of you who don't know this society was the first to be formed in the world in which all devices and anything which is related to medical implants was started as a society for artificial organs. And the first dialysis machines, the publications on that was first published in this. So this was a keynote presentation in Chicago, I think 2-3 years ago, including we've modeled blood flow in the circular village looking at strokes. So this is good. So Indian modeling is world class. So as a consequence of this, we've had several requests from overseas companies, including from Bay Area, to do contract research on modeling stuff. So that's the good part of it. We were successful in fact, I worked with the Department of Physics in the Baba Atomic Research Center in Bombay, and we developed a new biomaterial, nano material, polyurethane embedded with magnetic nanoparticles for use as an actuating membrane in artificial heart pumps. And this got a US patent a few years ago. We got a US patent for an LVAD and a few other things with an Australian company. So up to the design part, working with computers is pretty good in this country. So now comes the bad part. Accelerated wear testing to bench test for blood device compatibility is limited. Sri Chitra Tirunal Institute in Trivandrum is DBD funded, and it's the only one that I know which does this. And it's not always easy to approach them. So tomorrow you have an idea for a new dialysis machine or a new dialysis cartridge, or perhaps a liver perfusion unit, and you want to test whether it's compatible, doesn't destroy platelets or red cells or cause destruction to other things. You don't really have an FDA approved lab with which you can take it to the market. There are no freestanding commercial labs for testing according to FDA standards or component sourcing. They perhaps exist, but they're not easily available database of their existence, only word of mouth. So that's That's sorely lacking. The funding for these, certainly the government funding is very bureaucratic. I'm sure there's a lot of money available for research funding in India, but to a large extent is heavily skewed towards public institutions, central institutions. And it's actually a mistake to think that people outside of central government institutes either lack the intellect or the interest to research. So I give an example. We developed a very low cost temporary heart assist device costing roughly around 50,000. And this is uh, animal work we did with on a sheep model. As you can see, that's a sheep. So we used an enteric balloon pump to drive this. Now, the interesting thing is, first of all, doing animal testing in this country is virtually impossible. The curious thing is every implantable device requires mandatory animal testing data to be allowed to be used in human beings. And yet the very thing that you desire and demand is not possible in this country because, first of all, it's impossible to get permission. The animal rights activists are strong. So even a simple acute experiment is not possible. So most of the time we are forced to do our animal work. Even as we speak, we have developed a heart organ perfusion system with the Indian Institute of Science in Bangalore, which can prolong the duration of organ ischemia for the heart up to 10 hours. We got funding from DBT, but we're stuck at Animal Ethics Committee because it's impossible to get animal ethics approval for this. So the research organization threatens to take back the money that they've granted. There is very little coordination between the different limbs of regulatory agencies. So the ugly part, I mean, even that is workable. So we can take your animal work to other countries. The cost might increase, but at least it's possible. So as I speak, most of our animal work for this is being done either in Sydney or in Leuven in Belgium. But the most important thing, which is a mess, is the regulatory framework. There's no clarity. There are not enough experts from diverse fields, unlike the US FDA. There's no clarity on requirements for a device approved for human implants. So tomorrow you design a wonderful implant for something. Who gives you permission whether it's good enough to be used in human beings or not? There is no clarity. So there are major reforms which are needed in the Indian FDA. I give an example. If you go to the United States FDA website, this is what you find. It's very clear. And you look at the Center for Device and Radiological Health, the organizational structure is very clear. And the guy who's heading it is this man. They have applied mechanics, they have biomedical physics, they have biological chemistry, material science, the whole works. And this person has worked in the industry, in orthopedics, in Zimmer labs for making instruments. So people who head this have a real world feel and experience, who worked in the industry and then come and control the regulatory affairs. So they know what the challenges there are in taking a product to the market. And look at the specialties under which this segment is controlled, including virtual reality. And if you look at the biological sciences, these are people who have actually done work in this area, who are functioning or practicing oncologists. And interestingly, I was at this meeting when even things like computational fluid dynamic validation of models, the FDA sets benchmarks. In fact, this is a paper which is presented in the ASAR meeting in Chicago last year, a couple of years ago. And it was presented by an FDA employee. He's a PhD from Stanford. And they present the benchmark that they expect the device manufacturers to adhere to. So they give us problem like a model nozzle for blood flow and and they have a set of results, and they expect the lab which are participating to have comparable results. Similarly, for a blood form benchmark model. So this is in contrast to the organization of the Indian FDA. If you go to the Indian FDA, and this is done by CDSCO, this is the website of the Indian FDA. There is one drug controller, one joint drug controller. So the Indian industry treats drugs and devices as the same, which is the first problem. And this is the kind of notification numbers you have. In India at present, only notified medical devices are regulated as drugs by the Drugs and Cosmetics Acts of 1940 and rules made in 1945. And the even import of FDA-approved products is time-consuming, arbitrary, and uncertain timelines. It's steeped in. So it's very difficult. I can't understand why a product which is FDA-approved for use in the United States and being used extensively requires 2 years of approvals before it can be taken into the market. So let alone making devices of our own. I gave an example of vascular process. I have some inside knowledge of what happened. The TTK, the same company which made the heart valves, had an ambitious project of making a vascular graft. Initially, they made a knitted graft. And by the time they got the animal work done and some kind of approvals, the market had changed. Nobody was using knitted grafts, and the market had shifted to coated grafts. So they did some work, and in fact, they published it. But by the time, and there's no clarity. So the DGCA wanted 200 implants to be followed up for 2 years before they give approval, with no clarity and funding. So after spending several years and several crores in 10 years, the project was shelved. And I know at least 3-4 examples of them, including a centrifugal pump. So we are developing an LVAD, which is suitable for the Indian market, which is affordable. And we found it easier to work with an engineer in Sydney, and the animal work is being completed in Sydney and Leuven in Belgium, and we hope to bring it out to the market next year. So in conclusion, while we have enormous talent, which is undoubted, and especially both clinical and engineering talent is in abundance and the envy of a lot of other countries, major reforms are needed for Indian device manufacturing. Opportunities are huge. We need a lot more clarity on regulatory approval. We should stop treating devices as drugs. We need device-specific guidelines. We don't need to reinvent the wheel. We can borrow from the US FDA, the Japanese FDA, the CE mark, Australian TGA, but we have to have them in our website with some clarity. We have to involve specialists from multiple disciplines in a transparent manner. Tomorrow you're making a blood pump or a catheter or anything else, you need experts in CFD or simulation to be part of the approval process from prestigious institutions. Over the next few decades, we need to focus on creating experts in specific domains like rotary blood pumps or oxygenators or implantable biocompatible power systems, surgical robots. Only then we'll have the expertise needed, and with courses offered in the university. The Indian R&D funding might be ample in terms of amount, but it needs to be more nimble and less bureaucratic. If you get a fund at all, it takes 2 years by the time the amount comes to you, and there are a lot of slips between the cup and lip. The Indian device industry needs to look beyond trading, because that's what is most lucrative at this point in time for most of them, and look at funding research as an investment opportunity. And we really need top-class animal facilities. You can't have a situation where you don't permit any device to be used for human implants unless it's tested in animals, but you don't allow us to test animals and then say make in India. It really has no meaning. And finally, we need to relook at medical and engineering education. It might seem a little preposterous on my part to comment about engineering education, but I think both of them require some tweaking in a very significant way. Medical education, in my opinion, in this country is very practical. A lot of us get to do a lot more practical procedures than our counterparts in the West, but we lack sorely in research methodology. At least I did, and I come from the same medical school as Dr. Reddy. I did my undergraduate in Jipar, Pondicherry. So like in US residency, perhaps 1 year is devoted to research here. Maybe you should have MD, PhD training programs, and medical schools attached to big technical institutes are important. And engineering perhaps needs more hands-on training. As we speak, the reason I got this meeting postponed at 3 o'clock was we were in a meeting exactly with this guy in Aachen. If you look at the Department of Cardiovascular Engineering in Aachen, 8 of the 10 implantable cardiovascular devices, including the impeller pump and the other kind of ECMO systems, were developed by them. So they seem to have a seamless integration between industry and academia. and he goes and works in the industry as a CEO and then comes back and joins the industry. That kind of freedom should have. And I think these are a few of my thoughts. I'm sorry I didn't speak particularly about transplantation, but I thought this might be more pertinent to the kind of conference you're having. Thank you very much. I think perhaps we can have discussion at the end of it. So I invite Dr. Ravi Chandran to commence his talk.
Thanks, Bala. I will start at where Balakrishnan left. The coordination or the interaction between engineers and doctors have been very poor in this country. And of course, in 90s, where we got involved with IIT, that's sort of starting point with a dialysis machine failing, and then the engineer helping us to sort it out. So I'm going to be just the opposite. I'm going to talk on the basic, outline the basic aspects of kidney transplantation and raise questions about areas where engineers could help us. See, I would request maybe Bala and Srinivas Reddy not to see it because this is all basics. It's only for people, lay people who are not into medicine to get some idea where we require help. Why do we require kidney transplantation at all? Chronic kidney disease or a prolonged kidney impairment is pretty common. People are not aware. Almost 10% of the Indian adult population have an impaired kidney function. It depends on the sensitivity of the test that you do. So it's a huge population which has an impaired kidney function. Even if a small percentage of that lands up in a situation requiring dialysis and kidney transplantation, we cannot manage it. The term end-stage kidney disease, ESRD, what we call, that means a person has reached a stage where he cannot survive unless he has dialysis or kidney transplantation. So this is a huge number, and probably we are treating less than 1% in this country who have this end-stage kidney disease. The approximate number of transplants done in this country is about 5,000 per year. This is before the COVID pandemic. Now, of course, it has come down because of the COVID. The US does about 25,000 kidney transplants a year. So why should we do transplant for kidney failure? See, as against dialysis, we could depend on devices. We could depend on dialysis machines to live. The restoration of life, is full life, is only with kidney transplantation. So all the functions of the kidney cannot be duplicated by the hemodialysis or the peritoneal dialysis. And the life expectancy after a successful transplant also is much more. We thought when we started transplant in 80s, we thought these patients would not live more than 10 years. Nowadays, I have patients who have crossed 30 years of kidney transplantation. Some facts about the history of transplantation. The first successful kidney transplantation was done in 1956 in the US between identical twins. Why I mentioned these identical twins is, in those days, the ability to prevent rejection was very low. So technically, although you could do a transplant, it would get rejected. So the successful transplant could be done only between identical twins where the body does not recognize self from non-self. In 1972, India, we did transplant. Two centers, CMC Vellore and KM Mumbai, where Bala also did his post-graduation in cardiothoracic surgery, where I also did my nephrology. Bala may remember, there was a surgeon called P.K. Sen. He was a cardiac surgeon. He was the first fellow to do the kidney transplant team in the KM hospital. So how does transplant work? Transplant works on the fact that the kidney that is removed actually grows, it hypertrophies. If I do an ultrasound in a donor or in a patient 3 months after transplant, you will find that the kidney has actually increased by a couple of centimeters. So the single kidney starts growing or hypertrophying and does the function of both kidneys. That's how transplants are successful. Both the patient is doing well, as well as the donor who gave the kidney also does well. Obviously, you can have live transplant, which is the commonest form of kidney transplant in this country, where a relative donates. This is now governed by the Organ Transplant Act, which says that only a blood relative like mother, father, brother, sister, grandparents, etc., only can donate. Other than that, there are only certain exceptions where they can donate a kidney. So a live transplant has an advantage that you can evaluate the donor properly. You can evaluate the patient properly. It's not done as an emergency. And then the surgical procedure itself is much shorter, and the kidney preservation is good, and the outcomes are very good. So traditionally in India, live donor transplantation have been very common. Small percentage, about 10% of the transplants are deceased donor. When I mean deceased donor, these are brain dead people where the heart is pumping, but the brain is dead. So the organs are still perfused, and this is picked up. Actually, in Tamil Nadu was one of the state in the country which did the maximum number of deceased donor transplants. Here, the organ has to be preserved for longer, which involves solutions and special ways to perfuse the organ. So what are the criteria for choosing a live donor? Obviously, the person has to be healthy. The person has to be between 18 to maybe 60 or 65 years, depending on the centers, so that the kidney function is adequate. And overall, the person's health is also good. See, the donors are fairly safe, except that during the surgery, they have a risk of anesthesia or the surgery itself. And subsequently, in the long run, they can get high blood pressure or a protein leak. So we have to make sure that the donor is fairly healthy so that he remains. The priority is always towards the donor and not the patient, so that the donor lives well even after donating a single kidney. The deceased donor, one of the important things, the criteria are a little different, where the brain dead has to be declared by the specialist. And more important is that very often these people are on ventilator and they can have severe infections, so which prevents a successful kidney transplantation. Briefly on the transplant procedure itself, usually the left kidney is chosen for removing for certain technical reasons. And we always choose the less functioning kidney from the donor because the patient should be left behind with a better functioning kidney. The important advance in the technical aspect about 20 years back is the laparoscopic organ retrieval, which makes the surgery much less painful, and the donors can be discharged very early after the surgery. In deceased donor, the procedure is a little different. So you'll find that there is hardly a scar when you do a laparoscopic donor nephrectomy. Once the kidney is removed, it has to be cooled to about 6 degrees, and a cooled solution is perfused through the kidney to get rid of the blood products, and then also to bring down the core temperature of the kidney. So the organ is preserved. Normally in live transplant, it lasts for only about half an hour. Again, the kidney is reimplanted, put into the patient, and then it starts working. So it's not a great concern, but in deceased donor transplant, organs might have to be stored for longer periods of time since they have to be transported across long geographical distances. In the recipient itself, the kidney is placed in the front. The native kidneys or the old kidneys are not removed. It's placed in the front for technical reasons again, because you have to connect to an artery, a vein, and the ureter tube to the bladder. And the kidney should be in a position so that if tomorrow a imaging or a biopsy has to be done, it should be fairly superficial. So the advances in transplant and technical advances have not been great, because laparoscopic surgery itself is being done. Robotic kidney transplants have also come into. The advances have not been, the surgery by itself has not made a great change. It's been for the last almost 20, 25 years, more or less, the technical complications are very low. Surgical complications are low. Very well-trained surgeons operate in many, many centers, and the outcomes are very good. The problems are more on the medical aspect, where immunological matching is the most important thing. We got to identify that the match is the best. So the body recognizes self from non-self and tries to reject the organ out. So we got to identify what is the antigen structure of the patient. There is a lot of research and improvement. The same way we identify in the donor also his ability to, of course, the antigen structure of the donor also, so which will sensitize the patient or not. So same thing falls with the immunosuppressive drugs. We have to use medications to suppress rejection at the same time, not reduce the patient's immune system totally, and he succumbs to infections. So we have to have a very balanced view where we cannot allow the organ to be rejected. At the same time, we cannot allow a person to have infections. So the important complications on transplant are rejection, as I said, where diagnosing rejection itself requires a lot of the advancement. Still, we are depending mainly on kidney biopsies, but other markers, biochemical markers are being developed, urinary tests which could pick up rejection from other causes of kidney dysfunction are very important. How to prevent rejection, patient compliance is very important. Patients have to take medications lifelong. So the immunosuppression drug, could you use once a month injection so that they don't reject? All these things, tremendous research is going on. Infections, again, we cannot immunosuppress more, as you have seen, like in COVID, where the mortality can be extremely high. One of the problems when we started transplants and trying to follow the Western protocol, we used to have patients, a lot of patients dying out of infections. Infections are more common in our country. So we have to modify so that and know the local infections pattern to handle them. Malignancy, again, by disturbing the immune system, history of malignancies occur more in patients. So thank you. I've just briefly outlined and just let you out so that you could ask questions. I would leave it open so you could ask me where are the areas which are important. Thank you, Bala.
You have to unshare your screen.
Yeah. Is it unshared?
I don't think so.
Yes.
Now?
Yes, it's unshared.
Yeah.
Yeah. Okay, I think Dr. Reddy, can you start your presentation?
Thank you, sir. Can you see?
Yeah.
Okay, thank you. Thank you for the opportunity, and thank you to Balakrishnan sir and Swamina and for the introduction. So, Dr. Ravichandran sir, both of them are very senior colleagues. So I'm actually a very junior person compared to their experience in their specialties. So my talk is going to be mainly about what are the areas in liver transplantation where there is an opportunity for interaction between engineering and medicine to improve things. And I think Dr. Ravichandran sir has given a very good explanation about how transplantation works in general. I think the principles of transplantation are the same for liver or kidney or for the heart and lungs. Basically, the liver is damaged because of chronic liver disease, and that is replaced by a new liver, either from a cadaveric donor, someone whose brain has stopped working, so he's declared brain dead, and the family agrees to donate the liver to another patient, or from a living donor. So it's a family member who donates a part of his or her liver to their family members to replace the damaged liver. So the difference, probably the slight difference, is that I think liver transplant patients are probably a bit more sicker at the time of transplantation because they don't have dialysis as an option to keep them stable before the transplantation. The surgery is definitely longer than a kidney. And the reconstruction is a bit more complicated because there are more multiple blood vessels to be joined up and there are multiple bile ducts to be joined up. So that increases the risk of a more stormy post-operative course and complications. Now, when we look at what are the three main areas of research in liver transplantation, I think first is reduce the need for liver transplantation, which is probably looking at how to decrease the risk of chronic liver disease, which I will not cover. The second is how to increase the usability of donor organs, especially organs which donated retrieved from brain dead donors. About 25% of all livers that can be transplanted cannot be transplanted because the liver is not of satisfactory quality. And the third is how to improve the success of transplantation. I think these two areas are what, as a transplant surgeon, I would look at in terms of improving outcomes of transplantation. Now, there are a lot of work is already being done in the West and in the Far East, and to some extent in India also. And many of the things that I'll be covering briefly today have already been worked up. So there are some which just need indigenization. So it's already available commercially in the West, which probably needs to be indigenized to our country's needs. The second type of research is where the basic concept is available, where the principles of the technology are already available, but they need to be brought to the bedside into clinical practice. And the third is simple blue sky thinking. So, something that has not been done before. Can we do that? So, and is this all possible in India? And obviously, the logistics and the bureaucracy is something that Dr. Balakrishnan has already discussed, and I don't want to go into that. I'm probably still young and foolish enough to think that with time things will improve. So when we look at how to improve organ utilization, I think the most important thing, which both Dr. Balakrishnan and Dr. Nathan have alluded to, is the amount of time the organ is kept outside the body. So when a liver is taken out from a donor's body, and if it is transplanted within, let's say, half an hour, 45 minutes, there's not much of damage going on. But when it is in a different hospital and it has to be brought back, there are a lot of things that delay this this movement of the organ from the donor hospital to the patient's hospital. And depending on whether it's in the same city or if it is in a different city, you might have to use road, you might have to use flights to transport these organs. And time is tissue in transplantation. The longer the organ is outside the body, the less chance that it will work well. And different organs have different ischemia times, or times when it can be kept safely outside. For a liver, a maximum of 12 hours is what we would consider as safe. Anything beyond 12 hours, you're looking at a higher risk of the liver not working. And the problems in India are obvious. The amount of traffic that's there. You cannot actually transport an organ safely during daytime hours through most of Indian cities unless you have an ambulance blaring the siren and the police create a green corridor for you to transport. So how can we deal with this situation? And this already has been tried in the US, and they've started using what are called as medical drones. So I'm sure most of you know that Amazon has been using drones to deliver consumables to homes in the US. And the first report in the US of using a drone for transporting kidney has already been reported 2 years ago. And I think this is something, the technology is present. It can easily be used in the Indian setting. And it is something that would be very useful in India to transport organs, simply because the logistics of transporting it across multiple modes of transport in India is slightly more complicated than what it is in the West. Now, what are we looking at in terms of using drones for transporting organs? I think first is obviously design and manufacturer. We need to, the manufacturer need to know what kind of drone, what is the amount of, what is the weight that the liver has to, the drone has to carry. I mean, we had an interesting discussion with a team from IIT, I think a couple of years ago, when this report about a kidney being transplanted came up, and they were working on a drone to transport the liver. And the liver weighs 1 kilogram. So maybe if the drone can carry 2 to 3 kgs weight, is that enough? And we had to tell them that the liver weighs 1 kilo, but it actually is put in 2 liters of solution, that's 3 kilograms. And it's put in an ice box, which probably has about 10 to 15 kilograms of ice. So effectively, we're looking at a drone which can carry 20 kgs of weight. So, I mean, it's not just a simple picking the organ up and going. It has to deliver the whole package. So these are some things that, interaction with the medical team would help engineers, and interaction with an engineering team will help us doctors in deciding, actually, is it technology, is it feasible for us or not? And the key for this is the 3 S's. It has to be fast enough so that it actually is better than standard air travel. it has to be stable so the organ doesn't get damaged while it's being transported, and it has to be safe. So there shouldn't be problems in terms of delivery, losing track of the drone, organ landing up somewhere else, and all these things have to be looked at. And for this, like Dr. Balakrishnan said, there are a lot of gaps between the cup and the lip. So you need to have proper trials. You need to make sure that the drone takes off and lands correctly. We need to have the regulatory approvals to allow drones flying with with human organs. We need to have the infrastructure to manage these drones and to monitor these drones. So these are all things that something that we can look at, that we should look at, but the technology is present. It's already been tested in the US. So it's not something that completely out of bounds of our imagination. I think the second area that probably is relevant to all organs, both kidney, heart and lung and liver, is organ preservation. The current standard of organ preservation is static cold storage, where the aim is to cool down the organ as quickly as possible once it comes out of the donor, using ice and preservation solution, because at lower temperatures, the metabolism of the organ decreases. So for every 10-degree reduction in the temperature of the organ, the metabolic rate halves. So if you bring it from 37 degrees, which is the human temperature, to 4 degrees, you can actually reduce the metabolic activity of the organ to around 12% of normal. And so the damage to the organ because of lack of nutrients or oxygen slows down. But like I said, time is tissue. So the longer the organ is in ice, the more damage it undertakes. So the chance that the liver will work after transplantation becomes lesser as it stays outside for longer times. Now, the improvement in this is are the new ways of preserving these organs. So the current technique which is being worked on and is currently all the rage in liver transplantation is normothermic perfusion, where the organ is not kept in ice, it's kept at body temperature, that's 37 degrees, and it's continuously pumped with warm blood, which is continuously given glucose and oxygen. So the blood is actually nourishing the liver while it is being transported and while it's being stored. So these are multiple advantages. So you are delivering oxygen and nutrients to the liver, so the liver doesn't get damaged. It actually might help the liver in repairing damage that has been caused during the organ retrieval process. So your organ, which is preserved with normothermic preservation, might actually be better than an organ which is taken out from the donor and immediately transplanted. And the third and probably a more interesting possibility is that because the liver is actually working in the machine, you can actually see how it is working to know whether the liver is working or not. And there have been a lot of research over the last 15 to 20 years, especially in liver preservation, to develop systems which can be used. And the principle is simple, and we do have machines now which can do this. This is an Organox machine which is developed in Oxford. I remember one of my seniors, again from JIPMA, was doing research in Oxford with Professor Friend when he was developing this machine on pig livers. This was 15 years ago. And finally, now it's come to actually it's now commercially available. It was brought to India 2 years ago. It had a short run of about 6 months, and then it went out of the market simply because it's too expensive. So for each patient, the additional cost of using this machine for an organ is anywhere between 5 to 7 lakhs. Now, this is something that's almost impossible in the Indian setting, because most patients would not be able to afford a machine like this for their organs. So this is something that's probably not feasible in our country, but it's something that can be Indianized in our country, because the principle is simple, technology is available. It's somewhere between a dialysis machine and a cardiac bypass machine. And if it's done in India, the cost can significantly come down. I mean, if a machine like this is available at a cost of, let's say, $1 lakh per patient, it will be much more extensively used, because it then forms a very small component of the overall cost of transplantation. Whereas if it is 7 lakhs right now, as it is from the international market, it will never be used in our country. And this is very good technology. And if it is available freely, it can be used. So this is one more area where I think we in India can actually develop a machine which is cost effective and useful for liver transplantation. I think there are other areas which I can briefly go through. For lack of time, I'll leave this. Okay, this is something that I've always been interested in. It's something that we can potentially work on. Now, in the post-transplant period, how is the graft? Is the graft working well? Are there any problems to the liver? Is the blood supply to the liver okay? Is it producing bile all right? Is the bile getting into the intestine? They're all very important questions for a transplant surgeon in the first 1 week to 10 days after transplantation. And for this, we depend on blood tests. We depend on ultrasound scans that are done once or maybe twice a day. But the problem is they can be done twice a day, which means you don't know what is happening the remaining part of the day. After a week, if you decide not to do it, then you don't know what is happening to the liver unless the organ is affected significantly, that it starts affecting the patient function. Now, what we should remember is most of the changes that happen to the liver, they take time to present clinically, which means even if the blood supply to the liver stops because of a blockage in the blood vessel, you'll only know that maybe in 12 hours time when the liver actually starts getting damaged. But that is too late to do any interventions. You need to know it as soon as possible. And for this, there has been recent work on how we can actually use a continuous monitoring. So this was published in Nature, I think last year, where they've used a millimeter scale ultrasonic implant into a pig to look for blood supply in the pig muscle, in the sheep muscle, on a continuous basis. So suppose we have something like this implanted into the patient's body near the blood vessels of the liver. You keep it for a week, you keep it for 10 days, and you'll get an all continuous tracing, just as you get an ECG tracing of your heart on the monitor. As long as the patient is ICU, you can get a continuous tracing of how your liver's blood supply is, or how well is your liver getting oxygenated throughout the ICU. This is something that can help us in picking up any problems very early on, so that you can treat it. This is another example. This is actually from the cardiac side, where they've developed a wireless sensor that they put around an aortic valve after aortic valve surgery to check for aortic blood flow across aortic valve. And this is again something that the sensor delivers the information directly to your mobile phone, so the patient can actually have an continuous tracing of how the valve is working, whether it's doing a good job or not. Your surgeon will be able to know what's happening. And this is something that can be used even in liver transplantation. You can look at to see how the blood is flowing into the liver, how the oxygen is getting into the liver. Is the liver tissue well oxygenated? Is it producing enough bile into the all these things can be very nicely seen if you can develop the technology of using these micro devices, which can be implanted at the time of surgery, at the time of transplant surgery itself, to monitor the thing. So this is just, I think I will finish now, and we can probably discuss. Thanks.
Okay, thank you, Dr. Reddy, for an interesting talk. So, sir, how do you want us to do this? We answer questions from the audience, or we have a discussion amongst ourselves first?
We have a couple of questions that have been asked from the audience. So it's in the chat box. I can read it for you, and whoever wants to take it can take it, and then we will have the discussion amongst the three of you. So the first question is, 3D printing is emerging as a potential option that could address organ availability if it is successful. So your thoughts on this, please.
Okay, I will bat first. I think 3D printing of organs for a transplant is still way off to be clinically applicable. I think people are looking at 3D printing of organelles. There is some work done where they look at tissue-grown, say, lung cells along with blood vessels and 3D printed. But a full-blown organ like a liver or a heart or a kidney, I think we are not quite there yet. It's futuristic. It can happen at some stage in the future, but what is possible in terms of 3D printing is substitutes for the organs. I speak from the point of view of the heart. You could actually 3D print out a small LVAD fairly cheaply, quickly, for a temporary assist device which can function for a month or 2 months. You could 3D print components of those pumps fairly quickly. So that is possible at this point in time. Increasingly, I think hospitals are having a 3D printer inside to print out connectors and stuff for even ventilators. But 3D printing of an actual organ is at this point in time, it appears in articles in Nature and PLOS, but clinical utility is, I think, a fair distance away. I think the other two people can chip in with their comments.
I think I would agree. I think 3D printing organs is going to take time. They have done. I mean, they have done very basic things like blood vessels and trachea, 3D printed and transplanted. But that's because they do a single job, which is a mechanical thing. But whereas organs like the heart, lungs, the liver, and they also have a lot of physiological functions, which cannot really be replicated by just printing out the shape or the structure of the thing. What's lacking there are the cells. So we've been doing some basic stuff on using 3D printed scaffolds for hepatocytes to grow in, to form like a small liver organelle. So I think it's all very early. It's just still in the experimental stage. It will take a long time to reach clinical fruition.
Second question is, now, genetically modifying the cells or tissues using CRISPR-Cas help in reducing immunological rejection of organs?
Yeah, I think, yes, genetically modifying could help. Obviously, we require a match and reduce the antigenicity of the cells. So basically, the leukocyte antigen is the most important thing which determines the immunological response. Some cells don't have the leukocyte antigen, like the RBCs, it's okay. But where there are antigens, HLA antigens are represented, I think modifying it would make a big difference, especially in those people who are already sensitized. So there are people who undergo second transplant, third transplant, fourth transplant. So these people have been subjected to enormous antigen load, and you find their antibody levels are extremely high. So I think genetic modification could make definitely an impact.
I think this is also a more immediate appeal, I think, has been in the field of xenotransplantation, which, depending on which school of thought you ascribe to, you could say that it's going to happen next year, as one cynic said, xenotransplantation is the future and it will always remain the future. But in reality, there are people threatening that this can happen as early as next year. So, to a large extent, xenotransplantation is going to be possible only by genetically modifying some of these stuff.
Third question is, do we have an ideal animal model that is available to test the blood material interaction?
Yes. I mean, I can take this and the others can. See, people have worked with a lot of large animal models. The original model that was used for heart valves was the dog, and dogs tend to clot very easily. So, in fact, that delayed the development of heart valves considerably because they didn't realize that different animals clot at different rates. Sheep don't clot at all. Sheep in general are anemic. So you tend to underestimate the thrombogenicity of a product if you use a sheep model, and you overestimate it if you use it as a dog model. In fact, there was a very cynical statement that dog is not a man's best friend because it held back prosthetic valve development by a decade because of this. So we now have a fairly, at least I speak from the domain in which I work, a fairly standardized approach to which animal is best suited for which kind of experiment. I suspect that might be true for liver and kidney as well.
Yeah.
Next question is on, what are the indigenous technologies that could be developed to reduce transplantation cost?
I think a couple of them Dr. Reddy had mentioned, and I will use this as an opportunity to address those things as well. Drones is attractive. It's even more attractive for heart because unlike liver, where you have 12 hours of time, we have 4 to 5 hours. So the problem with drones is you can't have a 20-kilogram payload when then the logistics of the drone and the size of the drone and the cost goes up. So you need to define the weight that it's capable or you need to carry. So we developed, when we started this project about 3 years ago, looking at it with the Indian Institute of Science in Bangalore. So then the building the drone part is easy. In fact, there's a company in Chennai which even commercially has built a drone for us. It's ready to fly. The key thing is to design the box or the payload, as they call it. So as a requirement for as a technical input requirement, the 1 kilogram is too less, as he said, even though the heart weighs less. So we started off with the 5 kilogram as an input weight. So the 20 kilograms is pretty much what even our organ boxes weigh, because a lot of it is eyes. So you don't really need eyes. You could use other technology to keep the organ cold. So we've developed a pretty neat system in the Indian Institute of Science. I think it's gone for a patent where the actual box weighs less than 5 kilograms, and it's with a proficient system of cold crystalline solution, where we have extended the time of organ viability and ischemia to well beyond 7 to 8 hours. But one of the things that he mentioned in his talk, which I like very much, about sensors and stuff, everything uses an animal, whether it's a pig or a sheep, and that's where we get stuck. For you to develop something, you really need some. You can't hold our hands and tie it behind and then say imported from Oxford costs money. This is so. That's why my talk was perhaps unfriendly towards the existing scenario, but that's a harsh reality. An Oxford perfusate of 6 lakhs for in a heart or lung domain is a steal. For us, it costs 45 lakhs, the disposable components. So then we keep talking about the cost. So this has to be addressed not just by doctors, but people like you working in academia and engineering institutions. So this is a concern for everyone. We need to get together and sort it out. Otherwise, our grandchildren will be having seminars like this talking about the same thing. I'm sorry, I don't mean to sound cynical, but this is our reality. Yeah, Ravi.
Fortunately, kidney transplantation costs are very low compared to heart or liver.
No, whatever.
But our basic problem has been in the drug compliance later. See, for years, in kidney transplants, you cannot afford to skip your drugs. And previously, fortunately, now the medical expenses come down. Imagine the cost of a monthly expense of 10,000 rupees 10 years back. It was a big amount.
But
so
even for you tomorrow, you need to develop a new chemical, for instance, for a continuous dialysis or whatever. Regulation is there, and yet we don't know how to tackle it. So you might, with all your brilliance, you develop a new dialysis solution for whatever, continuous dialysis or whatever. Who gives you permission to market it?
No.
How do you test the safety of it? So these are fundamental things in any country, in any industry, if you're going to make any meaningful contribution to products. Otherwise, it's meaningless.
Yeah, I think you're absolutely right. You remember when we started in 97, acute dialysis
you were trying to build a cheap
we had a problem, machine.
And where is it? Nowhere.
I mean, nowhere, absolutely nowhere.
So that is not because you're not a brilliant guy. We are able to send a rover to Mars. You think you can't build a stupid dialysis machine or a stupid pump?
Yeah.
So you understand. So this is it. So this is the elephant in the room that you need to address.
So these are the 4 questions that had come out.
Okay. Yeah. So okay, if you, how much more time do we have?
We have another 10 minutes.
Okay, I'll start a panel discussion. I mean, my co-panelists are amongst the most brilliant guys in this country. So I'll put a Do you think it's a good idea to have an engineering school attached to a medical school? You think is that a fundamental issue plaguing Indian innovation in devices?
I think absolutely right. It should be the other way around also. Engineers should have a biology class. Both should have. The interactions. This is the issue which was raised by our mutual friend Krishna Kumar. The medical college should be, and the campus of the engineering college should be located. They should be together. So the interaction between the engineers and doctors have to be more. And we have to be trained in engineering basics. Absolutely right. No question about it.
And the other thing is, I don't know whether it's today, how true it is today. In my time, I entered JIPMER at the age of 16. I barely knew what the hell I wanted to do with my life. Most of us enter because you pass some stupid exam, your father asks you to enter. So at a later date, when you develop other interests, we are not allowed to take lateral time off and say maybe do a PhD in engineering physics. So it's not as though we lack the intellect to do that. The Indian system is very brutal in the sense that it forces you to take a decision at the age of 15 or 16 on a path, and then thou shalt not deviate from that path. So that's also something which needs to be addressed. You need to be able to have a flexibility. You could do a BTech in mechanical engineering and suddenly have an interest in cardiovascular mechanics and join a medical school. Why is that not allowed here? It's allowed in every other country in the world.
Yeah, absolutely right. I don't know whether you recall Prakash Kesavaya. He did his engineering from IIT Chennai. Krishna Kumar knows him. And then he did his MD medicine in the US. And actually,
only in the US, you can't do it here. It's impossible.
Yeah. so the man talks, I mean, he has so much of formula in medicine, which we don't have.
Yeah.
You feel left out.
So that is another thing. And the third thing is, even in our medical education, what is our exposure to research? Zero. I mean, I all of us have studied in amongst the best institutes in this country. I mean, I was interested to hear about Dr. Reddy from JIPMER and PGI. I went to JIPMER and All India Institute, and then joined Ravi in Bombay in KEM Hospital, which was the foremost center at that time for cardiac and kidney. And yet, what was our exposure to research? Zero. How many rad experiments did we do looking at models of organ failure?
But
that's something which we need to have.
Your boss was not bad, Dr. Parulka. They used to have an impedance plethysmogram. I don't know whether you recall.
Yeah, I remember that, sir.
They used to do a number of gadgets. He used to be interested, you know. At least.
So we need exposure to research, and I think the engineers require exposure to more practical work. That's my humble opinion. I don't mean to intrude on your domain, but a lot of, at least the guys I worked with in IIT, all these people that I showed, most of them end up in financial institutions after doing this kind of work. So it is meaningless in my opinion. If you do hardcore, at least you can say one thing about medical education in this country is that majority of us practice medicine, even at this age. We don't branch off. And if this recent pandemic has taught us one thing, the only thing we didn't have to import was doctors and nurses. Everything else we had to import. So at least to that extent, we need some renewed look at how education in these two spheres is done in this country, I think. And the other thing is access to, Dr. Swaminathan, I'm sure, runs a wonderful research and technical institute in this country. So if somebody had an idea or needed a problem to be solved, how do they approach you? There's no mechanism to approach. A lot of device manufacture in India is not done by IIT types, but by the second level in ITI or in Coimbatore or Ludhiana. And they might be good artisans, but they don't have the scientific background. So how do you approach technical or big universities? They can't even cross the gate. So that's something you need to make it possible for anyone with an idea to come to you.
Yeah,
that's something you need to put up in your thought.
That's how we that's the reason why we doing the series of discussions where we trying to identify people with an idea wherever they are, to connect with them and then connect them with the clinicians and see whether jointly we could develop indigenous products. And of course, our website and contact details are available, and the facility is open for everybody. In fact, right from the year that, from where we started, research as a separate wing, all our facilities have been open to, to all the researchers in the country. So we do a lot of animal studies for people from outside, a lot of analytical instrumentation and characterization facilities for, people who want to get it done or who don't have access to them as well.
Anything else you want to add, Dr. Reddy?
No, I think you said everything, sir. I think things are maybe getting better. I think in terms of exposure to research, I think there's probably some interest because now everybody knows that you need to publish. So to publish, you need to do some research. The problem is most of it is just clinical retrospective studies. What will actually drive science forwards is basic research, for which facilities are very limited in our country still. I mean, like you said, every university in the US, in the UK, will have the engineering college and the medical college in the same place. So in the campus, you meet everybody, you can share ideas, whereas that's not a possibility here. And the other thing is funding. I think funding has to be fair. In our country, you get funded if you are in a central organization or if you are in Delhi. I think
yes. So I find it strange that all the funds have to be distributed out of Delhi, and yet all of us are big taxpayers, right? I mean, we are denied the very benefit that we contribute to.
I think funding has to be based on the idea and rather not the connection.
And this distinction between public and private, I visited the chairman of the director of DST few months last year. And he point blank said, you might be as bright as you, whatever. We can't fund you because you're from private institution. We are citizens of this country. NIH funds us, for God's sake, in this country. If I have a good idea, I can get funding from the NIH sitting in Chennai, but I can't get funding from our own DBT and DSC sitting in Delhi because I don't work in the government. It is meaningless.
There is a lot of money for funding. It's just given off to
the same few institutes.
Yeah, absolutely. And if you apply funding, they'll say how much, how much have been funded before? Because if you funded before, you get more funding. If you've never been funded before in India,
okay. I'll end up with a very brief example of what I had experienced. I showed that sheep with a small device that we had developed. So we got funding from DBT for, I think, 4 or 5 crores. And the meeting was in Delhi. I remember the date because this was the day the Prime Minister was sworn in for the first time. And the only question they asked was, how much will you sell it for? I mean, I found it odd that a technical meeting to look at the viability of this product should talk about the cost. The cost is the last. It is not dictated by, it's got so many other factors. And then I was doing this research in collaboration with the TTK company. So they came and they wanted a DSIR certification. So they had it for their pharmacy division. They didn't have it for their valve division for some reason. So they insisted that unless you have 2 full-time PhDs, we can't give it to you. It didn't make any sense to me because any kind of design work or CFD work, we can always outsource it. Why would we have to hire people? So, and eventually we never got the funds. So a lot of it is very bureaucratic and meaningless because it's written in some form. And we have no access, no forum where we can even discuss this frustration. Anyway, this is about, I don't know how useful this meeting was, but this is pretty much what we have to say.
I think, you brought in inputs from various directions, from the regulatory perspective, from the bureaucratic, from the clinician's angle, brought in inputs even from an academician point of view, integrating a medical and engineering campus and so on and so forth. And definitely this was a very fruitful and a useful session for us and the viewers who could now go back and think about some of those devices that you have discussed in this meeting and to get back to you on with the design and prototypes being developed. So with that, I think we will close this session, and once again thank you all for your time and in addressing these important and critical points that you have in fact taken up. And thank you very much, and thank you.
Sure. Thank you.
Right, Bala.
Thanks.